welcome to this month's episode of Picture of Health. I'm your host, Lauren Lengyel. According to the World Health Organization, HIV/AIDS remains one of the world's most significant public health challenges. It is critical to know the basics about this disease in order to reduce the risk of becoming infected with it. That's why our special guest this month is Dr. Daniela Chiriboga, a doctor of infectious disease at the Florida Department of Health in Polk County. Dr. C, thank you so much for being here. I've heard some people call you Dr. C, so I'm just going to jump on that bandwagon, but welcome.
Thank you very much, Lauren. Yes, that's what my patients call me, Dr. C, and most of my coworkers.
It's a hip thing. I wish I could pull off a Dr. C, but I guess you have to have like a medical license or something. We're going to get started and talk a little bit about what it is that you do with the Department of Health in Polk County.
I am the lead physician over communicable disease, which means that I am not only over their HIV programs, but also STDs, TB, immunizations, and rabies and hepatitis. I see patients in the clinic, but I do also have a little bit of a leadership role. And what I love about my job is that I get to see people living with HIV throughout the different stages of their illness. So I can see someone who's been positive for many years and is really healthy, or I may see someone who is coming in to care for the first time and who's very sick. So it gives me a variety of knowing people and seeing people who are either really sick or really healthy.
So you mentioned earlier, before the show, that we have an HIV/AIDS clinic. So tell me about that, like where most of the work kind of takes place. Is it in that clinic, or is it at the different Department of Health locations?
No, the health department has only one specific clinic that takes care of individuals living with HIV and AIDS, and it is located here in Bartow. And we see people, we're actually the only HIV clinic in Polk County other than one private provider, actually two private providers, one private clinic that also sees them, which means that we have a humongous amount of patients compared to other places where there might be many other doctors available to see people living with HIV and AIDS.
So the people that don't have, I guess, healthcare in place or things like that, are those the types of people that you're seeing in your HIV/AIDS clinics?
Not
that,
only.
That have those diseases?
Not only. As I said, the only other provider in the area is through Watson Clinic,
Okay.
and Watson Clinic only sees individuals with certain health insurances. So we see both people with insurance, without insurance, with Medicaid, Medicare, and also those who have no health insurance.
So there's just, to your point, there's just not a lot of places to go. So I guess before we can talk about the evolution of all of these people and how they cope with the illness and things like that, I guess we should probably talk about what this illness is and how it can be either transferred or contracted.
As you know, HIV is a virus, and it affects a specific part of your immune system called T cells. And as I tell it to my patients, there's two types of immune cells. There's T cells and there's B cells. B cells are sort of the intelligence part of your immune system. They're the ones that say, oh yeah, chicken pox, you fought that when you were 5, and this is the tool that you're going to use to fight chicken pox. Well, the B cells, that part of your immune system is not really affected by HIV, not in a significant way. Now the T cells, they're sort of like the frontline soldiers. They're the ones that are doing the fighting as the infection comes into your body. And those are the ones that are affected by HIV. So individuals who have HIV will have varying levels of compromise to how their immune system fights infection. Now, I know a lot of people, the next question you're probably going to want to ask me is, what's the difference between HIV and AIDS? So when you get infected by the HIV virus, there's a period of time during which your body is infected, your T cells are infected, but the number of T cells still hasn't been affected so much that you're really, really ill. At a certain point, and usually we count T cells, so when you get to a T cell count of about 200, usually you start having such a weakened immune system that you can start having what's called opportunistic infections. And those are the infections that should not occur if you had a healthy immune system. But if your immune system is weak, either by HIV or cancer or any other immune problem, then you are going to get sick from it. So something that if you're walking down the street, you're exposed to it, doesn't affect you, suddenly will cause an illness. Those are the people that we consider having AIDS. Those that either have an opportunistic infection or whose T cell count drops below 200, putting them at risk for opportunistic infections.
So I'm going to say this back to you to see if I understand it correctly. So these T cells, they're like the front line cells. So they're kind of like the infantry soldiers.
I like that.
When your infantry soldier count, that you've lost so many soldiers in this war with this pathogen or whatever you want to call it, you have a count of there are only 200 left. That's when you start getting into this AIDS classification. Is that correct?
Exactly.
Okay, I got it. So then what do, I know as this disease started to gain more notoriety and become more common or prevalent, or at least we're diagnosing it as such, it got a really, really bad rap. I may be getting a little off topic, but how is that different now in 2016 versus, say, like the 90s?
Well, first of all, you have to realize that when a patient sat, I was not a doctor in the 90s. I was a child.
You're so young.
But
brilliant.
If you had a patient sitting in front of you in the 90s and you told them that they had HIV, you were pretty much telling them that they would be dead in the next 6 months, especially in the early 90s before we had cocktails to treat HIV. As time went by and better medications appeared, individuals now do not have such a poor life expectancy. Someone living with HIV today has a life expectancy of about 70, and that's even higher if they're diagnosed early.
Wow.
Before their immune system's really compromised. Someone who has a normal T cell count at the time they're diagnosed, so they're diagnosed really early after they've been infected, has the same life expectancy as the general population. So the first thing about HIV that's changed is, and to take away some of that bad rap or some of that stigma, is it's not a death sentence anymore.
Right.
The second change is, I think when the epidemic first started, it was specifically associated with certain lifestyles or risk factors. And I think those stigma unfortunately still remain. People think that they're not at risk if they don't belong to one of those groups, or if they're not specifically considering themselves to have certain lifestyles. And I think people also still seem to assume that if someone has the infection, they might have some high-risk behavior. That may not always be the case.
Okay, and so the lifestyle and high-risk behavior would be like maybe IV drug users and that sort of thing?
Exactly. So mostly the infection was initially attached to, in people's minds, not necessarily always, but was attached to either IV drug use or to men having sex with men.
Okay. And I think that's really great now that we can look at the medicine in 2016 and say, hey, you know what? There's actually something we can do about this. So I did kind of pull us away from our little timeline, but as we've kind of talked about what HIV/AIDS is, how does one contract this? I mean, we kind of touched on it, but.
So as we talked about, there's still some groups that are considered more at risk, and there's only 3 ways that you can contract HIV, and that is either through sex, through exposure to blood products, or through exposure through the uterus of your mother. So that's called vertical transmission or perinatal transmission. The most common way that people will acquire HIV today is through sexual transmission. When we talk about blood products, that is extremely uncommon in the US anymore, but there were people who could acquire HIV either through transfusions or say through certain blood products such as the factors that are used to treat hemophilia. You can also become exposed, for example, through a needle stick if you're a healthcare worker, but those are much less common and the risk is much smaller than it is through sex. And then there's obviously the risk if you're an IV drug user and you're using dirty needles.
Is that, just out of my own curiosity, because of the diminished passing of the disease through blood transfusions and things like that? Is that why when you go to donate blood, they have like an 80-page thing that's like, did you go to this country and did you go to this country? Is that kind of what that's
Believe it or not, that's looking for other things, such as malaria, for example.
Fine.
But they do ask certain questions to see if you're at risk for HIV. They screen blood so well that only if you had just become infected in the last few days to weeks with HIV would you be able to still infect people. And that's why I said it's very unlikely nowadays to contract HIV from a blood transfusion, because they test blood with such a good sensitive test that if there was virus there, they would most likely find it unless it was a really, really early infection. And that's what the questions are supposed to be asking about if you've had a very recent exposure.
So what is the earliest that HIV or AIDS, obviously it wouldn't be AIDS, right? Necessarily?
Most likely not. Usually when you're just infected, you do not have AIDS.
Okay, so what would be the earliest time frame that you could really expect to detect HIV?
It depends on the test that's used. Some of the older tests or some of the tests that we still use, such as some of the rapid tests, have a longer, what's called window period. So that's the time that it takes for the test to become positive. Some of those can even have a 6-week window period. But some of the newer tests that we use can detect the infection within the first 2 weeks of being infected, 2 or 3 weeks. So it really depends on what test is being used. And the test that we use for babies, for example, detects the virus itself. So that could detect infection very quickly within probably a week or so of being infected.
Okay, we're going to take a break now. But when we come back, we're going to learn more about HIV/AIDS. And stay with us. You're watching Picture of Health.
I am a mother.
I am an entrepreneur.
I'm a journalist.
I am a singer.
A businesswoman.
I'm an artist.
An educator.
A sister.
An advocate.
A leader.
A queen.
I am a friend.
I am.
I am.
I am.
I am.
I am.
I am.
I am one of more than 1 million people living with HIV in the U.S.
We
are not alone. Let's stop HIV together.
Get the facts. Get tested. Get involved.
15 years ago, I was diagnosed with diabetes. It really was devastating. I did not want to accept that I was a diabetic. I was so ill at the time, and my health was really failing. It was to the point that it was very serious. I first heard about this program, Take Charge, University of Florida, from my neighbor. This class explains exactly what you are supposed to do. It has taught me exactly how to live, what I'm supposed to do daily. They care enough to take the time to explain everything to you in detail. From the beginning to now, I feel well. It doesn't worry me a bit about diabetes anymore. Now I know that I can live because I know how. And it has been a lifesaver for me.
Welcome back to the show. I'm joined in studio today by Dr. Daniela Chiriboga, the infectious disease doctor of the Florida Department of Health. Welcome back, Doc.
Thank you.
So, as we were talking before the break, we touched a little bit on how early you can detect HIV in a person. Do you want to just recap?
Sure, as I had said, it really depends on the test, but it's going to be somewhere between 3 weeks to 6 weeks after infection most of the time.
Okay. So when people are coming into the clinic at the Department of Health, are they finding out before they get there that they have HIV or AIDS? I mean, are they coming in specifically for screening and then you have to deliver some really awful news? Not as awful as it could be, but not very favorable. Or are they finding out from maybe another doctor or something like that?
Well, let me start by saying I'm lucky. I never have to deliver that news.
Oh,
someone's already gotten it from someone else, because we the patients that come in to see me are already infected, but the health department does do a lot of testing. So the ways people are going to be diagnosed are either going to be when they go to the hospital really sick, which is very unfortunate, but I'd say the majority of our patients still get diagnosed that way. Or they get tested by their doctor, either because they're sick or because they have a really smart doctor that decides to test their patients frequently, which is what should be done. Or they can have come in for testing either at the health department or somewhere else for a health fair or something like that. It seems like our younger population goes out and gets tested very frequently, which is great. So it seems like some of the younger people get diagnosed that way, whereas some of other individuals just get diagnosed when they're very, very sick.
That's really sad to hear. You said our younger people, so does that mean that the older population isn't as apt to say, you know, if I'm sexually active or if I am engaging in some sort of risky behavior, I should probably go and get a test to make sure that I'm taking care of myself and that sort of thing?
Unfortunately, that's true. I've had a couple medical students who have wanted to research that issue because nationally it seems like the older individuals tend to be more sick when they're diagnosed, and no one is sure if that's because they're less likely to test early or if it's just because older individuals get sicker quicker from HIV.
Okay. You're diagnosed with this disease. Then what happens? What's your next step?
As soon as people get the information, they're obviously very overwhelmed. This is something that is not easy to take, and just like any illness that is life-changing, most people need a little bit of a period to think things over.
Right.
Now, we are recently adopting an approach from the state called test and treat, which means that someone who's tested today and is told that they're positive would be seen immediately by myself. The DIS, the Disease Intervention Specialist, which is the person from our STD department that would most likely be telling them their diagnosis, would get them straight to the health department within 1 or 2 days to start on medication. Now, that's a process that we're starting to adopt. Not everything is ready to go, but that's how we're going to start to treat this, because, you know, there's no reason to delay. And as I said, life expectancy is so good if you're started on medicine as soon as you're diagnosed, and with the higher the possible T-cell count, there's no reason to really wait to get people into care. So this is something that's a little changing, because we're going to have, that's not what we're doing right now. But people want to seek out health care right away if they're diagnosed, be that at their doctor's office or by a DIS who comes in and gives them the news. They definitely want to seek out health care immediately, because they don't want to let themselves get to a T-cell count of less than 200 and an OI if they haven't already gotten there.
So as you are beginning treatment with maybe a new patient, someone who is diagnosed with HIV, what types of medications are there that you put them on, or is it just dependent upon their situation?
So we're very lucky today. When I started, and as I said, I was not treating HIV in the 90s, when people were really, really sick, and when they started out with AZT, where you had to take a break every 4 hours to take your medicine. But today, the medications that we use to treat HIV are somewhat easy to take. Now, let me start by saying we still don't have a cure for HIV. The medication is used to control the virus in the bloodstream, and in a minute I'll mention the advantages of controlling virus in the bloodstream. But we have at least 4 or 5 regimens that are 1 pill a day.
Wow.
So most people don't have to take a bunch of pills, and even those that are not just 1 pill a day are still very easy to take, very easy to take side effect wise. You know, again, if you go back to the early era of HIV, people would have so much diarrhea with the medications that they paired it to chemotherapy. Most of my patients now don't have side effects when they take their HIV medicine.
That's really incredible. I remember watching TV shows, and you know, the media always kind of paints things a little bit differently, but I'd always see 10 different pill bottles and things like that going on. So I guess it wasn't that far off, but just a pill a day. Huh?
That's the way it used to be. Nowadays, it's definitely not so difficult. But you know, I don't take my iron half the time, so I can understand when my patients tell me even 1 pill a day sometimes is hard to do.
Right.
It's not easy to keep up with medicine even when it's 1 pill a day.
So how does, obviously, treatment there is going to be a little bit different versus, somebody has AIDS, or is the term full-blown AIDS, is that a real term?
No, and I hate it.
Okay. So we're going to bust that myth right now. That's not a thing.
Yes, and the reason I say that is it's not really fair to call it full-blown AIDS, because AIDS is AIDS. And the other part is once you have an AIDS diagnosis, we maintain the AIDS diagnosis, and that's just because of reporting issues. They measure to see how many people with AIDS are in a community, and a lot of funding depends on that. So if you had people jumping from AIDS back to HIV, it would drive the surveillance people and the people with numbers crazy.
Oh, right.
So once you have an HIV diagnosis, an AIDS diagnosis, we keep it as AIDS, but that doesn't mean that someone is still always sick.
Okay.
They can get better. So we don't, and it gives a lot of stigma to talk about full-blown AIDS versus not full-blown.
Right. So let's just bust that myth right there. We'll strike those words from all of our vocabularies about AIDS and HIV. So how would you treat a patient who had AIDS versus HIV?
The medications used to treat the infection, the HIV infection, are the same where if you have HIV or AIDS. What's different is because your immune system is so weak when you have AIDS, we have to prevent opportunistic infections. And we use certain antibiotics to prevent opportunistic infections. So someone with a T cell count less than 50, for example, might not only take their HIV medicine, but might take 2 or 3 different antibiotics to keep them from getting sick, hopefully until their T cell count goes up above 200 again.
Right. So it's those opportunistic infections that can really be fatal.
Exactly. Most people living with HIV in the old days used to die of opportunistic infections.
Okay.
Nowadays, most people living with HIV die of something else, a heart attack, diabetes, complications, a car accident, and they just happen to have HIV.
I see. We're gradually getting past the stigma of, what did you do to get this disease? Because sometimes it's not what you do. Sometimes it's just kind of situational and it happens. But what about those people who want to continue living full lives and they have a partner, or they want to get married, or how does that work?
I love your question.
Okay.
So, there's several ways in which we can protect someone, a loved one who's not HIV positive, if we are HIV positive. So the first thing is you have to remember that just by starting medication, a person reduces their risk of transmitting HIV by 96%.
Wow, those are great numbers.
Isn't that amazing?
That is amazing.
So, and that's why we look to start individuals with HIV. As a public health measure, obviously for an individual, I want you to get better, but as a public health measure, I also want you to not have virus in your bloodstream, because then you're much less likely to infect others.
Right.
The second thing is there are certain medications that can be given to the uninfected partner. So we can use something called Truvada, which is an HIV medicine that we use, and you would take it every day. But that would decrease your risk of acquiring HIV from your infected partner. And that's called PrEP, pre-exposure prophylaxis, and it's very effective. The other thing is, say for example, a lot of my patients want to have babies, and so if it's the male who's infected, we can give his female partner PrEP during the time she's trying to conceive. If it's the female that's infected, then we just keep her on HIV medicine, and we have a certain protocol of, we also give the baby medicine once he or she is born and test the baby. But the risk of a baby being born with HIV to an HIV positive mother who is in care is less than 1%.
This is actually a very, very manageable disease now, if you're responsible about it.
It is, and being responsible about it is very important. But I don't want to give the message either that living with HIV is easy, because I don't think it is. I think people pair it, say, for example, to diabetes, but most people do not want to acquire diabetes.
Right.
Most people don't want to acquire HIV either. It still is a life-changing illness, even though it has become much easier to live with HIV today.
Sorry, I was overwhelmed by all of like the positivity. Do you have maybe a story in mind that you might be able to share? I'm not sure if you can do that or not, about someone who's maybe had some struggles and then really, maybe their T-cell count came back up or something.
I'm going to be careful because obviously I can't violate
right.
HIPAA, so I'm going to generalize here. I have a lot of patients who come in who have been very sick, maybe have been hospitalized, who have T-cells of less than 50, and who may be very sick, say for example have cryptococcal meningitis, which is an infection in their brain, and who are needing to be cared for by their family members. They're pretty much at death's door. And as they stay in care, I see them getting healthier, start gaining weight, their hair grows back, they start looking good again, and they seem to start feeling well. And then they go back to work, and it's just amazing to see. And I've had a couple of those patients who have gone on to have babies, for example, and that always makes me so proud.
Oh, man. So real quick, before we get out of here, what are some of the things that you would say to people to continue minimizing their chances of contracting the disease? We just talked about how we would minimize passing it, but how can we minimize contracting it or protect ourselves and protect other people?
I think the most important thing to know is you should always know your risk and know your status. So get tested frequently. Mm-hmm. And also don't assume your risk, really know it. Talk to the people that you're with. Talk to someone if you're sexually active with them, get them tested. Use condoms, obviously that seems to be the no-brainer. Everyone
Right.
seems to know that, but we still forget that a lot of times.
And using them correctly.
And using them correctly is key, and using them for every mode of sex. A lot of people assume that oral sex is not a risk factor, and it is. Using condoms every single time that you have sex and every single time that you have oral, anal sex is really important. Getting tested, again, primary care doctors need to test their patients at least once in their lifetime, and every time that the person expresses to them that they are having risk factors. And for that, we have to have candid conversations with our patients, because if we don't ask, we're not going to hear about it. We also want to make sure that for those who are already infected, that they get the health care they need. Because if they don't get the health care they need, not only are they putting themselves at risk, but they're putting our whole community at risk because they're going to continue to infect others. World AIDS Day is coming up. It's December 1st.
Okay.
And I'd like to suggest and invite everyone to go out and get tested, know what their status is, and to not be afraid.
And folks can get tested at the health departments?
You don't necessarily need to come to the health department to get tested. There's a lot of fairs that happen. The health department can provide testing in-house, but when it's done inside the health department, there's a fee involved, whereas if you go out to community testing, it's done for free.
Okay.
If you call the health department, they can give you a list of sites where you can go and get tested, because our outreach people are really active in testing. And they're out there in the community trying to focus on places where people who are most at risk would be. But they'll be able to tell you can just go into this place and get tested this day of the week or whatever else. But you can always come into the health department also. Primary care doctors can do it too, though.
Dr. C, thank you so much for being with us. I feel like I've already gained so much knowledge, so hopefully all of our viewers will feel the same way. So thank you for being here.
Thank you. Thank you for inviting me.
Absolutely. Well, that's all the time we have for today. You can catch replays of this episode on Mondays, Wednesdays, and Fridays at 10 a.m. and 4 p.m. You can also watch all of our previous episodes on the Polk Government YouTube page. I'm your host, Lauren Lengyel. Thank you for joining me on this month's Picture of Health.